Good afternoon, everyone. I, Dr. Ritika Dhiman, welcomes you all to these virtual discussions, Osteo Talks, organized by Voice of Healthcare in association with Dr. Reddy's Laboratories. Via these discussions, our leading experts shall share their insights on the common early signs, symptoms to look for in females, along with management of osteoporosis in general. Before starting with this discussion, I would like to introduce our panelists for this session. I welcome Dr. Shah Waliullah, Additional Professor at King George Medical University, Lucknow, and Dr. Jatinder Singh Jaggi, who is an Associate Director, Orthopedics and Joint Replacement, Max Healthcare, Gurugram. So now, starting with this, I would ask a few general questions regarding osteoporosis awareness. So my first question will be to Dr. Jaggi. So Dr. Jaggi, what do you think are the common challenges in management of osteoporotic patients from a doctor's and a patient's perspective?
I'm sorry, I missed you. Your voice just went off. Can I? Yeah.
Yeah, so I was asking, what are the common challenges in management of osteoporotic patients from a doctor and a patient's perspective?
All right. Your questions has got actually two parts to it. I'll briefly touch on both of them. From the patient's perspective, the biggest problem is it's an epidemic happening. The
Right.
numbers are huge actually. The numbers are huge. When I say huge, it is huge. I mean, we don't have Indian data per se. We have American data. American data shows that 10% of the population has got low bone density. 10% is a, you can just imagine, Indian population, we are doing 130 crores, 140 crores, 10%, 14 crores. Now, what that does is it predisposes people to sustain low impact fractures, which we are seeing more and more because people are living longer. And unfortunately, that Indian culture of big family support structure is going down. So it's more of a nuclear family, people are living alone. So it's a huge thing which is happening from a patient perspective. The second thing that is happening which is going wrong is it's essentially a silent disease. There is no symptoms per se of osteoporosis. Very vague symptoms: low backache, fatigue. uh, Very elderly people might say कि थोड़ी height कम हो गई है, they start stooping. So there's no symptoms per se as such. Now, from a medical point of view, what is going wrong is osteoporosis is not being managed properly. Orthopedicians are have their hands full, and unfortunately, our colleagues from different specialities are also managing osteoporosis. So it's the treatment, right from investigations to the treatment part of it. The training is not focused in medical colleges yet on osteoporosis, but it's not that priority, I would say. So, from a medical point of view, it needs people from my fraternity also to really pick up this challenge to understand how going forward. So, it's going to be a partnership between the patient and the doctor. So, I think there's issues on both the sides.
Okay.
That is the essential, I would say, the bad where we are at it right now.
Understood, understood. So as you said that there are very vague symptoms, right? So Dr. Shah, would you like to intervene and can you tell us some common signs and symptoms to look out for osteoporosis?
I think his connection went off or something.
Yeah, I think we are not able to connect with Dr. Shah. So Dr. Jaggi, as you said that there are very vague symptoms for osteoporosis. There are no actual symptoms. So can you just elaborate on that a bit? That
Yes.
if I am thinking about per se that if I want to screen someone, so what are the common signs or symptoms that we should look into
Yes,
to?
see, the biggest thing is once we turn perimenopausal, menopause is a trigger point. WHO says that it's a
Okay.
trigger point, but perimenopausal, as a rule, we need to get bone density done. I think Dr. Shah is back. If he wants to take this question, we can take this. Otherwise, I'll continue.
Yeah, yeah.
Sure.
So, Dr. Shah, we were just discussing about the, signs and symptoms that you should look after, to screen for osteoporosis. So, what do you think are the main common signs and symptoms we should look for when we say when you think of osteoporosis?
Definitely. Actually, as Dr. Jaggi has already told us that it's a silent disease. So signs and symptoms are very few. In fact, we encounter this disease only after when the fracture happens. So if you want to ask about screening on home to screen, there are certain risk factors. If you are encountering these risk factors, then we need to send these patients for screening. If the age, elderly age, and the female patients, and if they are coming and they are saying, giving the history that the height is getting decreased, this is the most important. If the curvature of the spine is changing, like the thoracic kyphosis is getting exaggerated, the hump is coming down, your ribs are going down, and they are abutting your iliac crest. So these are the symptoms that the patient tell us that my height is getting down in course of 6 week, and there are certain risk factors like if the body BMI is less than 20 kg per meter square, and there are certain other risk factors like the patient is taking some therapy, like the patient is suffering from some disease like rheumatoid arthritis, something like this. Then in these patients, we need to go for screening this patient with certain like a bone mineral density and all that. Otherwise, symptoms are very few. As an orthopedic surgeon, we encounter majority of these patients only after the fracture that they are coming with us.
Okay,
So,
so
regarding
continuing with that, what according to you, what factors can determine the incidence of osteoporosis, like age group or demography or lifestyle or eating habits? So, what factors which determine the incidence of osteoporosis?
So they are like if we are asking about the risk factors, how they are occurring, there are two types of risk factors. One is modifiable and other is non-modifiable. Modifiable. In modifiable risk factors like the that you what you are asking about your diet, how you are going to change your diet because you can modify your diet because diet is really important. If you are not getting enough calcium, vitamin D in your diet, then you are getting prone to your these osteoporotic fracture because vitamin D is deficiency is rampant everywhere. So it's like an epidemic. Wherever you do this test, and you find all these patients are getting deficient with this vitamin D. So we need to take adequate amount of minerals, calcium, vitamin D in our diet. And there are certain other things that we can modify, like your lifestyle. There are two things: smoking, alcoholism. So if the patient can quit these things, because in the long term they can cause so much of side effect on your bone. So it's a difficult task for us. So we can like educate our patient to so how to quit these activities so they can their lifestyle can be managed effectively. So important factor like in whatever your diet can be improved, and the most importantly the exercises, particularly the weight bearing exercises, because in majority of the patient, like two types of patient that we get in old age, in male patient and female patient. In female patient we used to get advice. There are certain like if the patient is not having senile osteoporosis, like young post-menopausal females in 50s and 60s. So we need to advise them how to do exercise, like weight bearing exercise. They are very important, and the study shows that they have positive beneficial effect on the bone. So it is prerogative of us to educate them how to do exercises and which exercise. It is also very important which exercises that you need to do. So diet is one, and you need to take a proper amount of nutrients. It should be essential nutrient should be in your diet, and then afterward exercise. Exercise is most important. Then afterwards, like certain activities, sedentary lifestyle is not good. Your lifestyle should be active. You should adopt active lifestyle. You should be engaged in something so that your mind and your body is active, and it has positive impact on your bones. So all these things, like these are the modifiable factors that you can do. You can work on these things, and your osteoporosis can be prevented by virtue of these small steps.
Yes, rightly said that exercise and lifestyle changes are, mandatory for it. So, Dr. Jaggi, according to you, what are the existing care gaps, prevalent for patient with osteoporosis?
See, the biggest care gaps which we can see, which is happening there in the scenario, what is happening is there's a clinical challenge we have to see what is exactly happening. Now, the care gap is from a patient perspective and a doctor perspective. Now, there's a lot of, I will call it a gap is occurring because of awareness problems. And there's a lot of myths going on. Now, a lot of people
Right.
don't get treatment or start treatment for osteoporosis because of rare side effects of medicines. See, any medicine will have a side effect. Any. Now, you have to see when you take a side effect of a medicine that what is the benefit being happening. So, I'll give you a simple example of biphosphonates which you use routinely to make a bone strong. Now, it has two side effects. One is it causes osteonecrosis or the jawbone, it dies off. And the other thing is
Right.
people can have stress fractures in the hip bone. So these are extremely rare, uh, what I'll call it, incidents. Now, what happens is if the medicine saves 150 patients, this was a study done a few years back, and they actually quantified it actually. So what they found out was if 150 patients were prevented from having a hip fracture, two had it. Now you understanding what I'm trying to say?
Right. The
So this
incidence of,
incident, it prevented
yeah.
150 fractures, but two people had it. So if you look at it,
Hmm.
150 benefited and two lost out. So
Yeah, it's
that
about the risk and benefit ratio that you
yes.
are talking about.
The second gap which we are happening is the availability from where the state is failing the patients. Bone density, these sort of tests are not routinely done in a hospital setting. The cost is an issue. BMD is a gold standard. BMD is a gold standard. In a private setup, I work in a private setup. A three-side bone density is around 4.5, 5,000 rupees. This is only the bone density. Now you look at the blood test, you look at other things going on. So I think the funding is somehow osteoporosis is not taking uh, the limelight is not on osteoporosis as it is on cancer, as it is on maybe heart disease, or diabetes, uh, without understanding that osteoporosis, if your body is not good, you're not standing up straight, you're not able to walk, obviously your heart is going to have more pressure. Obviously, you are going to have a issue with your diabetes. So there is a gap there. And we are only talking about DEXA right now. Going forward, we are looking at diagnosis with the help of MRIs and CTs. Now, these CT scans which are being done to pick up bone density has to be quantified. We need DEXA will tell you a number, but if we really want to do quantification, we do something called as a volumetric CT.
Right.
Or it's called a micro CT. Now, these sort of things are not available at a general level. There is a problem of availability, one. Second is the problem of infrastructure. And the third is the biggest challenge, I would call it, is the lack of trained staff. Everybody can't do a volumetric CT. Every machine cannot do a volumetric CT. Sometimes we have to do a 3D reconstructive MRIs to really understand how. See, you might do a bone density and say the density is X amount. That's fine. But in the right areas, what is the exact amount?
Hmm.
So the gap is basically two ways: one from the medical point of view, and one from the patient point of view. Because see, for the patient, if there is no symptoms, you tell them please get a test done, which in a private setup or a setting which is going to cost them around 10,000 rupees, and then you have to eat medicines for 3 to 5 years. That concept comes to say, what is this happening? Why are we being even advised? मुझे तो कोई problem ही नहीं है. I have no problem. So why should I do this? This is another way of giving me more medicines or treatments which are not. See the gap which is there. can only be bridged with patient awareness. The battle
Right.
will be won. The battle will be won when the patient or the family takes that onus to say, my mother, my sister, or has turned postmenopausal. Every woman should make it her, like you do pap smears, and you understanding what I'm trying to say.
Yes, yes. The
If
screenings that are done for other diseases.
what hurts me personally is when somebody walks in from good families, very educated families, and you ask them, you are 65, 70 years old, when was the last time your DEXA scan was done? And they look at you and say, what? किसने बोला नहीं, हमने कराया नहीं, बोला था, कराया. See, it's so the gap is not only from, it's two ways. Sometimes these patients are being seen by the gynecologist or an internal medicine person. Even they should be it to their patients that these are certain things. And what I would say is that the government should come up with certain guidelines, or they should be like in the Western world. There are programs run. Patients are actively given messages on social media or through the information network. So these are certain tests to be done at certain ages. This gap which we are finding, this gap is, and I would call it an artificial gap, which can be very well covered, provided we set our minds to it and commit ourselves. We'll be saving so much of heartache and pain and trauma that it's phenomenal.
Yes, yes. You rightly said it that, preventive screening for DEXA scan, osteoporosis is not being done. That could be because people are not aware of the complication that osteoporosis can cause. For example, fractures. And you said that, if you have a stooping posture, then your heart has to do a lot of work. So I think the people are not aware of the fact that there may be complications that are related to osteoporosis which they are not aware of. So, and also preventive screening is also not done as they do for breast cancer or cervical cancer or diabetes and
Yeah,
hypertension.
that is exactly
Yes.
what I'm saying. That for a
Yes.
woman, postmenopausal woman, uh, this should be part of their screening. It should not be left as an option.
Right.
So, see, when you empower somebody and they start asking for it, the medical fraternity will always answer back. Right now, breast
Right.
cancer screening, cervical cancer screening, all these are being pushed, and in a good way. We are picking up. See, we have to look at the Indian subpopulation. Even with breast cancer, you'll be surprised. In India, breast cancer occurred a decade earlier than in the West. India has got a larger number of young breast cancer.
Right.
So,
People are not aware of
it's not,
osteoporosis as a disease.
yes, for them it's not a disease. So, see, you have to understand, it's not a disease for them. So it's very
Right.
difficult to tell them कि bone density वो ना इंडिया में there's that concept as per age होता है.
Hmm.
So it affects their quality of life. It affects their activities of daily living. It's accepted as a cultural thing. We have to re-educate that times have changed, and just pushing things under to say hota tha, these sort of things which can be addressed at certain times. Maybe yes, they were not addressed, but now when they can be addressed, we should open our eyes and face this head on, I would say.
Right, right. Absolutely right. So, Dr. Shah, what are the new advancement in the screening of osteoporosis, and at what extent are these advanced screening and treatment method accessible and affordable in India?
It's a good question. Right now, what we have like initially when this osteoporosis was diagnosed, it was based on the ultrasound guided ultrasound guided this bone densitometry. But right now, as DEXA has been declared as a gold standard, actually it is. So the problem that we are facing, that what we are discussing, that how to tackle this much of large population. So there are certain scores that had been devised, like that what we follow. That there are so many scores, like the commonly score that we all know is a FRAX score that will tell us about the fracture probability, that how's the risk of getting a fracture. There are several scores like OSTA score, a bone score. So we, by calculating all these scores, we are able to know what the fracture is and how the bone density is getting down. So there are certain scores that based on your bone mineral density as well. So by getting these scores, you are able to know the probability of fracture that your patient is might getting. So we are incorporating in our practice these scores as well. But other advances that we are getting in the screening, that like ultrasound guided densitometry, because as we have the large number of population, initially Dr. Jaggi told that but the population is about 140 million, 140 million, and if the only the 10% they are getting 14 million you have to screen. So how is it possible? The number of DEXA scans, they are very few in our country. So to meet this unmet number of patients, we'll have to go like devise certain things like screening. So for screening, like we can have like ultrasound guided densitometry that we can go. And the most important thing that we encounter in our practice, like by taking a history of the patient, and if the patient is having certain risk factor, then we need to take this patient for our for this BMD measurement, because we can't all screen all the patients. We can screen them, but we cannot do DEXA scan for all the patients there, because of the cost as well, and because of the lack of machine all over. Suppose I'm practicing, I'm person here in the medical college. So majority of the facilities they are available. Dr. Jaggi is working in a corporate. All the facilities are available. But if you go to a peripheral remote area, even the X-ray machine is not available. So in that case, how we are going to diagnose this osteoporosis? That is a major issue, because in the, like if you go to the periphery center, so we can diagnose this osteoporosis by DEXA. But if the patient is giving history, like the patient has got fracture because of the old age, so we can think of this is an osteoporotic fracture. If the facilities are not available, you can screen this patient, as this patient might be pathological fracture because of the osteoporosis. So we can screen this patient by even a sound guided densitometry. If the facility is not available, then we can refer to this patient, so that we can start early treatment and prevent future fracture by just incorporating these DEXA scan. And like what are the screening tools that you have asked? So these are the scores that we can go. So these are FACT score that commonly we used to follow in our practice. Otherwise, in my practice, what we do, like all the patients that we are getting in our department. So if their patient is having pathological fracture, we screen them by the metabolic profile as well as like bone mineral density, and we do a workup. Then we can start treatment as per our endocrinologist if it is required, if the patient is having certain metabolic problem. Otherwise, we do start by above. So it's important to screen first of all the history. If the patient having the history of decrease in height, or a familial history of pathological fractures or osteoporotic fracture, or even the patient has given the history of like wrist fractures or even prior fracture, then we can think of this patient is probably suffering from osteoporosis. This per se from the history of the patient. Then we can go for certain metabolic tests, and even the X-ray or MRI if it is done for any other reason. We can like spine MRI has been done, and we can diagnose, we can screen this patient even by the MRI that this patient is suffering from osteoporosis. Otherwise, mineral density is the gold standard is the DEXA.
Yes, Dr. Shah. We don't have, actually a rapid or a rapid test to do, so that we can rapidly check and test it with. Currently, we have a lot of machinery going around, so which is available in corporate hospital. It is not readily available everywhere. So that is, yeah, that is the main challenge. So coming on to the dietary aspect, so Dr. Jaggi,
And one
so
thing I would like to
diet,
add here.
yeah,
One thing
yeah,
I would
yeah.
like, what we challenge face in our practice. One more thing, in few times, like we advise patient for the DEXA scan, and we get falsified values, just because the data that we are including is from the Western data. It's not from the Indian data. So that is the biggest gap that I feel like in our practice. That the DEXA scan that even we are doing, it's not coming rightly, because our data is Indian data is not available to us. in that cases, history as well as all these points that I have told, they are relevant. So even we cannot rely DEXA scan fully in our practice.
Right, right. Because the Indian population and American population both are, have different aspect and, diet and everything, the environment which can contribute it to it. So, yeah. So, Dr. Jaggi, dietary, as I said, dietary habits in India are very different when we compare it to the Western world. The macro and micronutrient intake ratio in Indian food is different to the Western food habits. So, do you think this difference as a causative factor for osteoporosis incidence in Indian females?
Absolutely, there is no doubt about it. There is no doubt. Absolutely, there is. See, we have to understand a basic fact or a basic rule. There's a difference between animal protein and there is a basic difference between plant protein. Plant proteins are not that well absorbed. That is proven scientifically without doubt. Now, Indian subset of population is predominantly vegetarian in nature.
Right,
What that does is the patients are less, they are nutritionally they are weak. So the only thing they can do in India in a way is to look more at milk, cheese, milk products, green leafy vegetables, things like kale, these sort of foods which can increase their spinach is really pushed forward as the spinach has got a lot of calcium, but the calcium which is there in spinach is not absorbed actually. There it's also a lack of things. Again, India may we eat a lot of legumes, beans and rajma. Now these have got phytates. They don't let absorption happen. So diet has got a huge role, and we have to understand that females per se, uh, till now in the Indian subset of the culturally, I think metropolitans leave it alone. But if you look at the Indian population, which is rural, which is more, it's still a patriarchal society. Whether female or the mother will say, "Ki, I need to feed my husband, my son, my daughter, and then I eat." So her nutrition takes a backseat.
backstage. Right,
Now, what happens is, especially when you hit menopause, at menopause, you again lose estrogen. Estrogen is your bone protective. It's your protector of your bones. So you are going to lose bone mass. So at that moment of time, for you to be taking a proper diet, for you to be looking after yourself, maintaining a positive protein balance. So the problem is protein. If you look at a diet, a regular diet, you just go home, look at your plate. The most expensive component of the food on that plate is protein. Maybe it may be dal, maybe it could be chicken, it could be fish. If you look at it, there is a vegetable, there is a dal or a chicken, and then rice and chapati. Now your carbs and fats are the cheaper ones. Protein is a expensive part of the thali or your plate.
right, right,
So, and again on top of it, our protein intake is more plant in nature. So, and the quality of that protein or the absorption part of that protein cannot be compared to animal protein. So I'm not saying that we all start eating non-veg, but intelligence, understanding your diet, understanding your requirements, and understanding the limitation of your diet. See, that is very important. To understand the मेरे diet में what is missing. If I can't get it from the diet, do I take a supplement? Again, with supplements, there is so much of myths. कि कैल्शियम लेंगे तो हार्ट में प्रॉब्लम हो जाएगा. See, again, that's with anything in life. Excess or unregulated stuff is bad, but just on assumptions to say this is not right, that is not right. A lot of people at a certain age suddenly stop taking salt because WhatsApp पे आया था salt is not good for you. It's crazy actually. You sometimes see patients who have switched off completely because at that age, as you get older, the thought process becomes rigid. They have their own friends groups, they have their own Facebook accounts and myths. So it's basically on your diet also, it's breaking those myths to understanding that leave your rigid positions, start accepting what can be done, and working on the diet. And India is, you look at the size of the country, from north to south and east to west, your eating habits are so different.
Right.
You can't have one size fit all. So wherever you are, you look at your food habits. So when people say Indian food habits, I sometimes laugh. What is this Indian food habit? Now, which part of India are you talking about? So it's totally different. It's understanding what I need and what my diet is, and then having a very critical look at it and being okay. Look and then okay, this is what I take and this is what I have. Where is the common meeting point, and how do I take care of myself? I think for me, I'm sorry, I'm sometimes turn a bit critical on this. I sometimes call it is lack of common sense. We try to find answers in big in difficult things where the answer is so simple. You just go back to look at the basics. Just go back to the drawing board. Just go back to foods which your grandfather, grandmother were eating, and stop thinking of exotic foods and exotic things that usme kuch khas hoga. Your grandfather were fine. Their bones are much stronger than what we see people today. I'm a joint replacement surgeon. I am sometimes surprised when I do knee and hip replacements of people who are 70, 80 years old. Some of their bone quality stuns me. It's so good that you come out and think, wow, what have they eaten in their life?
Yeah, I think there is a mixture of both exercise. You used to do a lot of physical work back then, and the
Absolutely.
balance between as you rightly said, the balance between the protein, carbohydrates, and fat intake. So
See, we
our
have Ritika,
grandfather
we have
generation used to do physical
yes,
work
Ritika,
as well, along with
with
that.
the diet, what has happened with the diet is we are too much into processed food. We are all looking at easy life,
Convenience, basically.
convenience foods. Now, the convenience foods के साथ में एक बहुत बड़ा issue क्या है पता है? What has gone wrong with this convenience foods or this is that your nutritional value has gone down. The caloric value has gone up. So these foods
Right.
have a higher caloric value but lower nutritional value. The longer you leave anything on the shelf, the more you reheat things, you're losing the caloric value.
Hmm.
Oh, you're losing the nutritional value. The caloric value remains the same. So people are getting more chubbier, they are getting more healthier, whatever you might want to call them. But nutritionally, they are taking a hit.
Right. So, Dr. Shah, Dr. Jaggi has explained that diet has a major role in this osteoporosis prevention. So can you please enlighten us with what vitamins and minerals intake is vital to maintain a good bone health?
The most importantly, calcium and vitamin D that I already explained earlier, and the other minerals that I feel like that you need to incorporate are like manganese that has a role in calcium absorption as well as in the vitamin D absorption, and other like boron and vitamin K, they are also important. So the most important is calcium and vitamin D. The dosage that we need to like in our how to like there are two sort of patient that we have. One patient in the deficiency mode, and other patient like no, the patient is having deficiency but that has been replenished. So you need to maintain that. So regarding that, vitamin D is most important because we are deficient in our diet and we are dependent on sunlight, and because of our lifestyle, we are not able to pick up this vitamin D adequately. So this is the most important thing that we need to incorporate because our from our government, this is not fortified as if we compare from the Western countries. Their food has been fortified with vitamin D, but in our Indian scenario, it is not there. So we are totally dependent from like supplementation in our diet. So we need to take this vitamin D and other minerals and vitamin depending upon depending upon the patient requirement. If the patient is having risk factors, then you need to supplement with calcium and vitamin D and some calcium and other micro and macronutrients depending upon patient stage. If the patient is having deficiency, then we need to definitely incorporate, and otherwise just need to maintain the things for your patient. So healthy diet that incorporates this calcium and other like iron and all these things that are required for your bones and your body, you should take all these things.
Also, do all osteoporotic patients require mineral supplementation?
So,
See,
ma'am, it's not like that. Ke all minerals are required. It depends on how the patient is coming. Suppose the patient is having on hormone replacement therapy, or like if the patient is having rheumatoid arthritis, they are suffering from osteoporosis. So these patients are deficient in folic acid as well, homocysteine acid. There are gamuts of things that we. So we need to individualize the things. But otherwise, if you talk of me a general message, what you need to incorporate, it's a calcium and vitamin D. Otherwise, it's the patient specific. Depending upon the patient profile, you need to incorporate. If the patient is having osteoporosis, and sometimes we need to investigate as well. What's the cause of osteoporosis? Why this patient is getting? In that cases, we need to incorporate all these minerals. Vitamins.
Okay, right, right. So Dr. Jaggi, this is to you. That what do you feel are the unmet needs or expectations of patients, and doctors from the government institutes?
uh, okay. I'm sorry, my answer, Dr. Shah may not like my answer. Uh, what is happening is, I'll be very frank. In India, the government, maybe I've been trained in the UK. Come back from a system where the government is providing, and you see what the government is doing. Unfortunately, in India, the government is lacking woefully. Woefully means woefully. It's as far as osteoporosis is concerned, there is no government support, none, from what I know. If there is some patchy stuff in different medical colleges here and there, it might be because of interest of somebody. But otherwise, there is no government support. None. These medicines, these tests are not cheap. These medicines have to be taken for around minimum of 3 to 5 years. So there's a cost involved. Now, who pays for this cost? Now, there are different types of medicines which can be given. Some are tablets, some are injections. We have got newer therapies coming through. They come at a cost. And the issue with these treatments with osteoporosis is, it's not a one-off treatment. It's something like a SIP, where you open up a SIP account and you have to put in an installment every month.
Every
Uh,
month, yeah.
otherwise, otherwise you don't get the incremental
Interest.
interest or whatever. So osteoporosis is on the same pattern actually. So you can't have a tablet today for osteoporosis or an injection, and tomorrow you say, okay, apni. It doesn't work like that. So it has a sustained effort. It's a sustained uh, methodology to it. There's a method to the madness actually. It's very well documented. It's very well accredited. Repeat tests has to be done. It is a very well structured program. Now, unfortunately, where most of the population, 80% is rural population, and they don't even they've not even heard the name osteoporosis. Now you give them some tablets. Those tablets come with very specific instructions, how to take them and what to do and what not to do. Now the injections which are to be given, some of them are once a year, some of them are once every 6 months, some of them are once every day. Some of them need a cold chain. You cannot leave those injections out in the sun. There's a temperature to be maintained. Otherwise, the efficacy goes. Now, when you have to run this thing, there has to be a concerted government support. Even things like simple calcium, if you just go down today to buy a calcium tablet, a regular calcium tablet is around 10 rupees from a decent company. So, two tablets a day is 20 rupees. That's 600 rupees a month. Now, somebody who's not earning a lot of money, you understanding what I'm saying to say, Ritika?
Right,
So,
right. I understand. People
it's
are basically not aware of the fact
it's not
that
aware,
osteoporosis
and
is a
there is
condition,
no support.
basically.
There is no support from the government side to it. Most of the places will not have working DEXA scanners, because if a DEXA scan breaks down, the urgency to fix it is not there, as would be an urgency to fix a CT scan or an X-ray or an MRI. These injections, they need a repeated It's like a vaccination protocol that you have one now, then you have to have a second dose, then you have to have a second, third dose. So if it is not followed through, then what is the big deal of giving the first dose? So,
Yeah,
and
I think
because of,
first,
yes, and because the patients are not aware, they're not demanding it. So there's a gap on both the sides. So one, the government is failing the population, and the second, the population is not helping themselves.
I think the basic is that the acknowledgement of it as a disease. That is what I feel is the basic. I think you agree on that. I think this is what actually we were talking about. What are the upcoming novel therapies, and how they are improving the osteoporotic patient's health from a clinical perspective?
Ritika, initially we had only a few medicines, which were, we classified into two parts. The two parts which we classified is, one is anti-resorptive and the other is osteoanabolic. Osteoanabolic. Now, anti-resorptive, what it does is it prevents the bone from losing calcium. It's anti-resorptive. It's not being resorbed anymore.
Right. Hmm.
Osteoanabolic means it is helping to generate new bone. So there is a list of medicines or treatments we can give. In the anti-resorptive, we have got biphosphonates, right from zoledronate, alendronate. These are IV injections, they are tablets. And then coming to anti-resorptive, we have again got an injection called as a denosumab. And then when we come to, and also raloxifene, which is used in postmenopausal ladies. When you come to osteometabolic, we are basically looking at either teriparatide. Now we have also got a new drug called as abaloparatide, and we also have got something called as romosozumab. Now romosozumab is a newer form of denosumab. Denosumab is still well known in India, which is used once every 6 months. It's an Ranibizumab is not readily available. It's very expensive, but its efficacy is way more than denosumab. Denosumab is once every 6 months. Ranibizumab is effectively once a month. So these names sound very exotic, and teriparatide and abaloparatide. Now abaloparatide is a parathyroid hormone. Now these are novel therapies coming through, but we have to understand there is a cost to it. There is a cost to it. But before we go on to these novel therapies, I think we should first look at the basic therapies, like biphosphonates. The first line. We lot of the time talks about novel therapies, but novel therapies. I'm sorry, when you are living in a country where the basic therapies are not there, why are we even talking about novel therapies? I can give you a whole lecture on these abaloparatides and rosnumabs and all those things, but these are not cheap, and I would still, in my repertoire, I still call them as second or third line. My first line is still basics of biphosphonates, a good diet, vitamin D and calcium supplementation, and exercise.
Right.
Level two would be going into something like teriparatide.
Hmm.
So these novel therapies are coming in huge. Their data is phenomenally good. The results are very impressive. When I say very impressive, they are really very impressive. We have it has been, and we have also gone to which we call as dual therapies now, which we follow quite a lot. In which we use, instead of using only anti-resorptive or a metabolic anabolic osteoanabolic, we use both. So we use two drugs. One we use to prevent the resorption, the other is to get. So see, it's a treatment for an osteoporotic patient is so individualized that you can't have a size fit all. But instead of going to the novel therapies, the basic thing going through should be, how do we get as many people to start with the bare minimum what we can start with, get their bone health better. The biggest thing is help them not to reduce their bone health. See, most of these frac scores and all those things, they only start at beyond 40. So what goes wrong is we just think "ये मुझे नहीं होगा." If somebody is in the 30s, 40s, 50s today, and they start looking at their diet, their lifestyles, and a bit more bone aware, they will not end up with osteoporosis. So let's plan. When you don't plan, you plan to fail actually. So instead of looking at novel therapies, we should be looking at therapies which prevent you from getting into the hole in the first place. We are talking about how do we get out of the hole. Why do you want to fall in the hole?
Yeah, that's very insightful, Dr. Jaggi. So, Dr. Shah, when we talk about this, novel therapies, so do you think that there is a, connection with ethnicity to it, or we can follow the Western countries in these therapies?
Can you please repeat the question?
Yeah, I just said
Hello.
that,
Sorry for
we
the
were talking
connection.
about. No, it's okay. So we were talking about novel therapies, right? So do you think there is a element of ethnicity to these type of therapies that Indian population respond better to these medicines, or we should not follow what actually the Western medicine is giving us?
Ma'am, can you please repeat? Actually, I was not able to hear that thing. Just a lot of issues. Just can you please repeat what element that you are asking?
Yeah, I was asking if there is a role of ethnicity to these therapies, these medicines in osteoporosis that we are using here in India.
Yeah, yeah. Really, it's like our population is entirely different from Western population. Our build, our genetic makeup, and our diet, our all these things are different. So it's just like that you can't compare apple with oranges. So entirely, it's like the drugs that they are taking in the lifestyle they are living is different. So definitely there are ethnic issues with us whether these drugs are getting are suiting to our population or not. So definitely we'll have to look after this issue. We require studies whether this drug is suiting to our population or not. Depending upon studies and the data, we can follow okay, whatever the drug that is going to suit to our population.
Yeah, that is very insightful, Dr. Shah. So I would like to conclude this session, and coming towards the end of this session, I would like both of you to share your thoughts and insight or a one-liner message to our audience. So we'll start with Dr. Shah.
So I would like to message to to the audience to adopt a healthy lifestyle, incorporate exercises and meditation, mind rest, sleep. It's a good sleep that is very important for your health, and exercises and proper balanced diet. That's going to prevent us from osteoporosis because it is always and always better. Prevention is better than cure. So I don't want that you will be coming accused for the treatment. So prevention is better than cure. So go for healthy lifestyle, exercises, meditation, and good balanced diet. That is from my side to
Yeah,
everyone,
thank you,
listeners.
Dr. Shah. Over to you, Dr. Jaggi. You want to share any one-liner message to your audience?
My one liner is really a one liner. Its quality of life is directly proportional to your bone health.
Right.
If you're a car or somebody, if you maintain your integrity of the car, the first thing is the car should be good. If your bones are good, you stand straight, you're not an achy person anymore. So quality of life, if you have to maintain it, maintain your bones. I know it's a total
Right.
orthopedic message, but I'm an orthopedician. So I can't. I look at bones first before I look at heart.
Yeah, so thank you so much, both of you, for taking time for us, and your audience. So thank you so much, both the speakers, for having this session with us.
Thank you. It was very well done.
Yeah,
Very, very well organized.
yeah.
Thank you.
Thank you. Thank you. Have a good day ahead, Dr.
You all.
Jaggi and Dr. Shah.
Thank
God bless you all.